guys. I'm Dr. Saleh. I'm attending for everyone that I haven't met yet, but I think I've met you all, just the interns. Today we'll talk about one pill or sip that can kill in pediatrics. All right, so let's cover the epidemiology really quick. So we have greater than 1 million poisonings in children less than 6 years of age reported to the U.S. poison centers each year. So with pediatric ingestions, there's a bimodal pattern. So for accidental ingestions, most common under 6 years of age, with a peak incidence in 1 to 3. Intentional is more common in teenagers, adolescents, with suicide intent. Toddlers are at higher risk because the way that they explore the environment is through their mouth. They put everything in their mouth, they're touching everything, and also they weigh less. So it takes less of a medication to become lethal or toxic. So when we talk about the medications that we'll be discussing today, just remember that your average toddler weighs about 10 to 15 kilos. So we all love our developmental milestones. So at 6 to 9 months, they can creep, they can crawl, they can pick objects up. They can bring their hands to their mouth, but we're in a fist pattern. At 9 to 12 months, that's when they develop like pincer grasp. So they can pick up little pills, put them in their mouth. At 15 months, they can walk, but they really have to stoop and recover. So they can bend down to the floor, pick something up. So again, another high risk age. At 18 months, they can go in and dump pills out of bottles. So it's really important for anticipatory guidance to our patients, especially if they have a benign ingestion when they come in, to really talk to them about how to handle medications, household products, where to put them, and what the child will be able to do, and what they will learn to do in the next coming months. Especially for our patients, us, our family and friends, it's a good topic to bring up. So we're not going to cover all of them, but we'll just go through a case-based discussion. But I wanted to highlight this just to kind of raise awareness of, if you hear this medication or you see the triage note as you're scoping out the board, kind of raise awareness that this child may become one of the sickest kids in the ER, even though they look well right now. So you're talking about alcohols, TCAs, antihypertensive, antimalarials, benzocaine, the Oragel creams, caustics, herbals, oil of wintergreen, camphor, hydrocarbons, imidazolines, insecticides, opioids, and sulfonylureas. All right, so it'll be an interactive lecture, and I put a poll on. I don't know if it works. So if it doesn't work, just shout out your answers or throw it into the chat. So it's the start of your shift. A toddler is brought to the ED. 1 hour earlier, he had ingested a single tablet of his grandmother's glipizide. The child's asymptomatic, shows no signs of distress, and is playful. On initial finger stick, his glucose is 95. The nursing staff reminds you that you have a full waiting room, the hospital has no bed, and the mother is eager to leave. What's the dispo for this kid? So I'd be really excited if this worked, but I don't know. Is it working?
I think we're all fine.
Yeah. Yeah. Mine did.
Does it work?
Yeah, I got it. Yeah, I got it too.
But it's not loading into this. Or maybe I can. It's fine. We can shout out some answers, or maybe I'll look at the chat. Okay.
All right, chats. Some people saying C.
Okay. How do we feel? Agree with C?
Yeah.
Yeah. Good. Okay. So sulfonylurea. So that's the pill that he ingested. He's asymptomatic right now, but they do require a longer period of observation. So going through how sulfonylureas work. So they bind to the pancreatic beta cell, causes an altered resting potential, and it stimulates insulin secretion. So you have increased responsiveness of the beta cells to both glucose and non-glucose secretagogue. So basically, you'll have a significant risk for severe or profound hypoglycemia, which can be delayed. So even if the patient's asymptomatic, it really buys them an admission. So in this table, you have the range of time to peak, the half-life, and the duration of action. So they peak usually within 2 to 4 hours. The duration of action is about 12 to 24 hours, and they usually require about a 24-hour observation period. And they need frequent blood glucose monitoring or clinical monitoring to see any clinical signs of hypoglycemia. So recognize and evaluate for hypoglycemia, altered mental status, diaphoresis, dizziness, focal deficits, seizures, coma. So if they're normal glycemic in the ED, you at a minimum have to observe them for 12 hours. It's not something that you're really going to do in the ER. They need frequent glucose monitoring. You can get busy. So I think the safest option for them is to be admitted to the PICU. If they are hypoglycemic, you will resuscitate them with dextrose. So is everyone familiar with the rule of 50? So whatever concentration you choose, the volume per kilo should come out to 50. So if you're using D50, 1 per kilo. D25, 2 cc's per kilo. D10, 5 per kilo. So I know in pediatrics, everything's so complicated because everything's in mgs per kgs. And this is one thing that in a resuscitation is a little easier. Whatever the nurse has, kind of you can figure it out right there, what volume you'd like to give. Now, if you have to treat the hypoglycemia, that's when you have to start a triotide, because then it'll just be a cycle of transient hyperglycemia, then they'll drop again because the dextrose will stimulate insulin release, which will again cause recurrent hypoglycemia. So octreotide, you can give it IV or sub-Q. You can repeat the dose 2 to 3 more times every 6 hours. Any questions? All right, next case.
Older people also act like this too. They're very sensitive to these long-acting meds, maybe even more in some cases than teens. And you see them more, the sulfonylureas in elder people. I've had this year 2 cases of bad sulfonylurea toxicity in 2 elderly patients.
Yeah.
And had to use octreotide and had to admit them for a couple days.
Yeah.
Oh, I guess I have a question. The younger they are, you should kind of give them more concentrated dextrose, right?
Like D12.5 over D10.
Okay.
But D50, you'd prefer, you really should use that with a central line. I mean, if it's everything that you have, that's fine. But
Okay.
yeah, like in neonates, D12.5, yeah.
Okay, got
All right. You have a 12-month-old that's brought to the ED shortly after mom found him sucking on an Afrin nasal spray. She brought him immediately to the ED. She thinks she drank all of the bottle. He is sleepy. What do you expect to see? All right, good. Maybe answered.
Yeah.
Hypotension and bradycardia. So alpha-2 agonists, over the counter, you'll oxymetazoline and Afrin, Visine, and then clonidine as well. So locally, for the Afrin and the Visine, they stimulate the peripheral alpha-2 receptors, so they cause vasoconstriction peripherally, used to treat, obviously, conjunctival injection, nasal congestion. However, toxicity is seen in as little as 6 ml. So it's 1 teaspoon or 2 teaspoons of Afrin. They're so easily accessible. I think, I mean, the cover is a little safer now, but if anyone leaves it out, that could be really dangerous. And clonidine, the toxic dose for clonidine is 0.01 mg per kg. So not that much for a 10 10 to 15 kilo child. So central alpha-2 agonists, they bind and activate the alpha-2 receptors in the brain, decrease sympathetic outflow to the heart, decrease cardiac output, decrease heart rate, decrease the sympathetic outflow to vasculature, so you get hypotension. So they give you an opioid-like toxidrome, meiosis, altered mental status, respiratory depression, and apnea. And then cardiac effects from the sympathetic inhibition, you'll have bradycardia and hypotension. So the management is supportive treatment, always ABCs first, activated charcoal if it's within an hour. If they're apneic or somnolent, obviously you'll bag them, make sure that you have they're responsive to BBM. Then you can consider giving them Narcan. 0.1 mg per kg with a max of 2 milligrams. You can repeat it every 1 to 2 minutes as needed. You could, so in the literature, there's inconsistent literature to support Narcan and clonidine overdose, but you can try it as an adjunct to your treatment. And I'll discuss the paper in the next slide. For the bradycardia, you could trial atropine, and obviously with hypotension, IV fluid and vasopressors. Yes, that Silverberg brings up the next point. So the standard doses of Narcan actually don't work as well as higher doses. So in this study, they pediatric clonidine overdose in 51 patients. 80% of them had reversal of somnolence. 5 of them did have co-ingestion, but in this study, they found that if you increase the dose, they respond better. So it's something to think about when you're dealing with a clonidine overdose or oxymetazoline overdose. Other studies have shown that naloxone was inconsistent antidote. I don't think it hurts to help and use as an adjunct, but remember to go up. They went up as high as 10 milligrams per dose. So what's their disposition? If they're asymptomatic, you obs them for 6 hours, which is usually what poison control would recommend. You can discharge them. Most of them will develop symptoms within 4 hours. If they're symptomatic, obviously a PICU admission. If they're asymptomatic, but they ingested a clonidine patch, and kids do eat the weirdest things, you have to admit them because you may see delayed signs of toxicity. All right, case 3. 18-month-old female brought in due to concern for ingestion of her grandmother's blood pressure pill. Grandmother is unsure about the type of blood pressure medication that she is on. Initial vital signs remarkable for a heart rate of 65, blood pressure 68/30, respiratory rate 18, stats 100% on room air with a finger stick of 300. What did she take?
Who thinks A? Who thinks B? Okay, so kind of a split. A lot of people are saying A in the chat.
Okay. All right. So she's bradycardic, hypotensive, but hyperglycemic. So you're concerned about a calcium channel blocker overdose. So verapamil. The difference between a calcium channel blocker overdose and beta blocker. With beta blocker, you'd expect some hypoglycemia. Common question on your board. So our calcium channel blockers are nifedipine, verapamil, and amlodipine, diltiazem. Beta blockers will give you hypoglycemia and concern for ingestion with sotalol and propranolol. You can see any AV conduction abnormalities, dysrhythmias, hyperglycemia, specifically the calcium channel blockers, vomiting, and altered mental status. So dihydropyridine and non-dihydropyridine calcium channel blockers. So verapamil, diltiazem are older and more dangerous. They have an affinity for the myocardial cell. Dihydropyridine acts mostly on the vascular smooth muscle cells. But with children, if there's an overdose, there isn't as much selectivity. So like I said, vasodilation, hypotension, decreased AV node conduction, resulting in bradycardia, decreased insulin release, specifically for calcium channel blockers, so hyperglycemic, your tissues are unable to utilize the glucose, so you end up with the worsening metabolic acidosis. Management, I'll talk. We'll review it here. So, well, with all these situations, obviously you're going to get on the phone with toxicology sooner rather than later, so that you can attend to the patient and also have their input as far as the best algorithmic approach. So, ABCs, always first, and GI decontamination, so whole bowel irrigation and activated charcoal. With calcium channel blockers, if they're longer acting and the child's really at risk because of how much they took, you could think about multi-dose activated charcoal. Give them IV fluids for the hypotension, lower about 5 to 10 cc's per kilo, and monitor them for signs of fluid overload because they will have some cardiac dysfunction. And then in this order, if they're mildly symptomatic, this is kind of your treatment plan. If they're severely symptomatic, you're kind of doing all of this all at once. So if they're mildly symptomatic, mild bradycardia, mild hypotension, you can trial atropine. Then you can take it to calcium. If they respond to atropine and calcium, admit them for observation. But if they're severely symptomatic, then you'll go on to use glucagon, high dose insulin. So insulin is the first line if you have signs of myocardial dysfunction. High dose insulin. This is different than what we're doing for DKA. We're starting at 1 unit per kilo of bolus, followed by a 1 unit per kilo per hour infusion. That's 10 times more than in DKA. Correct their hypoglycemia and hypokalemia before you start the insulin infusion, and then they need close glucose monitoring. And as you're doing the high dose insulin drip, monitor their cardiac function. So bedside echo to see if there's improvement. You would expect improvement within 30 to 60 minutes. So as you're starting the insulin drip, again, you'll go circle back and simultaneously treat them with glucagon, fluids, vasopressors. And then if you see a profound drop in glucose after a period of stability, that's often an indication of clinical improvement. All right, and this is our last case. An 18-month-old girl is brought to the ED by relatives who are concerned that she may have ingested extended-release verapamil 90 minutes ago. The grandfather feels confident that the pill count is correct and no pills are missing. In the ED, the girl has normal vital signs and a normal physical exam, but is sleeping deeply at a time the parents say she would never sleep. What's the most appropriate next step in management? Do we want to treat her with anything? We don't. We should get finger stick because she's super sleepy. But what do you want to after that? E, yeah. So even though we don't know if she took it, you just have to have the safest plan for her. Admit her for monitoring. Verapamil is long acting. You could give her activated charcoal, but it's 90 minutes after, so if it was under 60 minutes. But again, if you're really concerned that they took a lot and it's even after an hour, I would personally use activated charcoal.
I guess I had a question about that, and this brings up a good point. She's speaking too, so how aggressive in pediatrics do you give activated charcoal, especially if you're dealing with 6 and under kids, is the most common in terms of taking these medications?
If I can wake her up and she can take it, I think a lot of people think that kids won't take it. Every time I've given it to younger kids, even if they get a little in, I feel happy about that. So if they're sleepy and not arousable and you're concerned that they may not be able to protect their airway, then definitely I wouldn't recommend it. But I would wake them up, put it in try multiple types of juices or fluids and see what you can get into them. Even with teenagers, I've had success.
Teenagers, I feel like could be
Yeah.
easier.
But in kids, they'll take
the younger kids vomiting and stuff like that.
Yeah, I've had some, I don't push them to take the whole volume, just leave a cup there, whatever they take, I think it's a success.
I've had this conversation with Dr. Weiner like multiple times, and he's always like, you know, try it. You should always try it. Don't be afraid. Usually they'll drink it. You mix it with something, they'll drink it. But at the same time, if they don't drink it, don't force it.
Yeah.
Like, don't like force it. Don't like, some people say, like, big people call it and say, drop an MG tube.
Yeah.
It's probably not worth it to drop an MG tube.
Yeah.
Like, don't be that aggressive, but like, for the most part, I agree with Mona, like, they will drink some of it. Yeah.
Yeah,
Then worst case scenario, they throw it up and maybe they throw up what was in their stomach. If they're awake, then they're protecting their air.
I will say my last case was calcium channel block overdose. We did give activated charcoal. He vomited onto the NICU, aspirated, intubated, and died.
But that's a little man. Yeah.
wow.
So, yeah, that is the concern if they vomit. You don't want
Yeah,
that.
so they aspirate and it's
very,
very, yeah,
Yeah, and that's what it like to make. That's why you don't want to like
Force
think
them.
about your YouTubes and forcing it, right? Like, let them drink what they can and stop.
unless you intubate them.
yeah.
That could be a consideration too.
Yeah, I had a calcium channel block overdose in residency. It was really scary. We were doing intralipid infusions, just trying anything and really desperate, and it was really sad. So yeah. So again, when you first see them, really take it serious. And if she is sleepy, but she can wake up, then try the activated charcoal. Even though grandpa thinks there isn't a pill missing, just give it a try, because that's the time you really kind of improve her outcomes and prognosis. So that's all I have. So we went through these, just keep aware and always refresh your, always look up, obviously, every medication that a patient takes, even if you see it in triage, but it's nice to be familiar with ones that can really be toxic, especially for toddlers, and keep those in mind. Any questions?
I was just wondering, the last time I gave activated charcoal here at Downstate, it came in like a toothpaste tube. Have you ever seen that?
I've never seen.
So what is the like, how does it come at county? Does it come as like a cup that you can drink?
Yeah.
That was
A
the first time
little-
I ever seen it as a toothpaste tube, and I had to tell this teenager to just like suck it out of a toothpaste tube like it was like ice.
Well,
But I'm just wondering, like, are they always like what does it usually come as? Usually just a liquid cup that you can just down in a gulp, or is it this thick, nasty stuff that you have to like really try to get down?
no, the nurses, every time I see the patient at the bedside, they've mixed it with whatever beverage that did, like a
It
juice.
always comes like that. It always comes as that tube. Every institution I've seen it, it always comes like that, and you have to mix it. You have to pour it out and mix it.
Yeah, but they don't really suck it out of the tube.
Just
Then.
squeeze it into something else.
Yeah,
All right. Thanks,
Yeah,
Mona.
I think, I was just gonna say, I think it's something that sometimes we forget. It's important to ask, you know, the parents and the grandparents what medicines they take and what medicines they have at home. Sometimes, you know, that's not a typical part of the history we would ask all the time.
yeah. And if anyone comes in for any foreign body ingestion, that's your opportunity. I mean, PEDS is all about prevention. So sit down, have that conversation. Where are you keeping your household products? I mean, we can tell crazy stories. I mean, in residency, I had a family that kept a drain cleaner in a Pediasure bottle under the sink. So of course it's going to attract a child. And so just a little, especially in our ER, we're not as busy, a little bit of education could go, or anticipatory guidance could go a long way, even if what they took was super benign. That's your opportunity to educate them and teach them about milestones and what will happen in the next 2 months and what the child will be able to do.
The other thing that I'm really terrified of is the unlabeled clear water bottle. So when parents are on like methadone and they have like these really crazy meds at home, you just make sure that they label things and keep them in a safe place. Because I had a kid in residency who drank a bottle of methadone and obviously expired. But it was because they didn't have it labeled, they didn't have it in an appropriate condition. No one knew what it was when the kid came in. So they had no idea.
So that's something you'll see more common. Your opportunity to educate our patients and their families, but child safety at home. All right, thank you guys.
Thank you.